Center's mission to catalyze research that integrates mental health and HIV prevention and care, guided by communities and practitioners seeking to end the epidemic. And today we're going to be highlighting a number of our pilot award recipients. And some of our presenters, we're thankful, will be co-presenting with their community partners. And we're going to learn more about our pilot awardees project aims and progress. And we're happy also to hear about your professional development successes and challenges and future goals that you have. I should have introduced myself first. I'm Patrick Rowie. I'm a clinical psychologist in the Department of Psychiatry. And I took over for Deepa as the director of the developmental core. Deepa's been great at kind of helping me transition into this role and very happy to be involved. The other thing that we're going to do today, for those of you who can stick around, we're going to have an informal chat with everybody, particularly for the early stage investigators, because we're really interested to hear from you about how our leadership on BIRCH can continue to support you in the coming year, what kind of structured supports that you might like, specific work in progress, connections with your peers, specific webinars that you might be interested in, and also thinking ahead to the renewal that we'll be submitting in August. Any advice that you have for the structure of the developmental core that could be helpful, anything from the amount of the pilot awards to the duration, any feedback or suggestions that you have would be great. And if we do have community partners who stick around to the end, we are also interested in hearing from you and helping us brainstorm how we might continue to support and offer things that might be helpful to community partners, anything from orientation to research design and helping you kind of think about outcomes and measuring outcomes that are important to you. That might be part of the pilot that you're working on, but it might be something totally different. And other support for other grant funding opportunities for you. So that's our goal for today. Thank you everybody for being here either in person or on Zoom.
Good morning and good evening. As I introduced before, that I'm working at the Muhimbili University of Health and Allied Science as a lecturer and psychiatrist. So it's Hannah to be here today to present this work that I receive funds from the University of Washington through BIRCH. So my also colleague whom we are working together is Peter, whom he's already introduced, but also our mentors, Professor Sylvia Kahaya. She promised to join. I'm not sure if she'll be able to make it, but also Professor Deepa Rao from the University of Washington is my mentor from University of Washington, and also Dr. David Ho from the University of Washington. So I'm real happy to have mentors who have been mentoring us to this field. So my work, which I'm going to present, is it focuses on doing adaptation and to pilot tests of one of the psychosocial interventions. This work, it will be adapted and piloted for the people who are using drugs, living with HIV, who are receiving the integrated medication-assisted treatment and HIV care at the Muhimbili National Hospital here in Tanzania. This is our teaching hospital. It is a national hospital here in Tanzania. So this psychosocial intervention, as I can say, it has been used among the general population, people living with the HIV. So next. I don't know if I'll be repeating. This is my personal background. I'm also about to complete my PhD in mental health epidemiology, which I've registered at the Addis Ababa University. I'm expected to defend it on May. I've already finished almost all the requirements. So hopefully by May, I'll be already defended this work. So apart from teaching at the university, also I do the clinical work at this teaching hospital where we see people with the different condition, mental health disorders, but also attending this client who have been used drugs, who are receiving the medication-assisted treatment. And also we have managed to integrate the HIV services at the clinic. So I also used to attend this patient. But I'm also as a mentee, I'm a mentee, as I mentioned, my mentor. But I'm also a mentor, mentoring the medical student whom I'm teaching them, both the undergraduate and the postgraduate student. Next. As part of my individual development plan, as I said, about to complete my PhD, but also another academic or career goal is to continue improve my research skills. And this is very important. What I think that will help to achieve this is to continue to apply to the short courses because I have interest on implementation science, but also I still need to get skills, especially on doing the mediation and analysis. Though through my PhD, I've managed to receive the training on the different research methodology, but I still need to continue to learn so that I can continue to improve my skills. And another career our goal is to continue to be a principal investigator with a small or mid grant as I received this one. So it also helped me to continue to learn, but also what can help me, I think, if I'm continue to get research networks and collaboration. But also through more publication, it will advertise and also help me to get this research network and also to continue to apply other grants so that I can to building my research skills and also move from the stage that I am now, but to another stage. And this also is very important because it also continue to build my research skills, as I said, but also contributing to the development of evidence-based research methods, applying evidence-based informed interventions, which can contribute to the improving the care of the people with the mental illnesses, also with who also have comorbidity with HIV. So this is also very important as a scientist. But also to continue increasing my visibility, as I said, that my passion on implementation science, also with the interest on working on the different interventions for research on mental health and HIV. And this also, what can support me to achieve this is also through stakeholder engagement, but also seeking grants, doing research and also dissemination, both local and international. And as this also is very important because it will continue to build my networking with different research partner and the collaborator. Next, please. So coming to the presentation, I'll have take through the background and justification of this study, but the objective, method, and preliminary result, because we have already do the first part. Next, please. So these are the abbreviations that are going to be used in these presentations. We have some of them which maybe we can say are very somehow common, but and others which they'll be used frequent for people who use drugs, living with the HIVs, and also the medication-assisted treatment, because that's also a clinic that where these people whom use drug are receiving their care, but also other abbreviations that are going to be used in this presentation. Next. With the background and rationale, it is well documented that the prevalence of HIV among people who are using drugs, it's more prevalent as compared to the general population. For here in Tanzania, the national prevalence for HIV is 5.1, but for the people who are using drugs, it range from 8.7 up to 51%, and it's more. Prevalent is more among those who are inject compared to those who are using other form of drugs. And we have evidence have been shown that through engaging them in the medication-assisted treatment, it's also one of the interventions that will, apart from supporting them from problem with the using of substances, but also because these services are provided in a very comprehensive, like for the instance in this clinic where we also do screening for the common mental disorders, but also a comorbidity of other infections like hepatitis, but also they receive psychosocial care and support intervention based on their assessment. So evidence have shown that through this medication-assisted treatment, these people who are using drugs can also they can achieve and also not only being able to quit from substance use, but also from other physical, mental, and also the overall well-being is being improved. Next. So in our country, we have this clinic. Initially, it started in year 2011. We started with one clinic, and this clinic that this study is conducted, it was the first one. And then up to this moment, we have 11 clinics in the country that we are around 60 million people. So with this clinic, as I said, that the HIV services have been integrated. And also based on the literature, even from that observation from this clinic, we have observed that through integrated HIV services and medication-assisted treatment, it facilitated the area treatment initiation, but also it improved their clinical and the psychosocial outcomes, also improving the adherence to the antiretroviral therapy, but also evidence have shown that it facilitates the reduction of costing because rather than having the duplication of the healthcare system. And this, we have evidence. Initially, it was only for the medication-assisted treatment, and then those who were HIV positive, we used to refer them to the other clinics. My apology. There's a problem with the internet. Sorry. Okay.
Thank you. Glad you're back.
Thank you. So next, sorry. Next slide, because this one is Okay, so I'm presenting brief about this psychosocial intervention, which it's called NAMWEDA. This is a Swahili abbreviation, which means that yes, together we can. This is an intervention that have been going on, and it has been continued to be rolled out with the people who are living with the HIV. And it was found that this intervention have helped them to improve their adherence to the antiretroviral medication, but also improving their clinical and psychosocial outcomes. So for this start, we plan to adapt this intervention to the people who are using drugs. This is it's a trained peer-led group intervention. So it's being led by the people who are living with the HIV themselves. So the same people who are using drugs who are living with the HIV. As I said earlier, that it has shown evidence to improve these psychosocial outcomes, such as depression, the self-efficacy for safe sex, about the HIV prevention and communication skills, and also HIV stigma. For the clinical outcomes is the achievement in their viral load suppression, improvement in their hemoglobin level, and also as well as retention in HIV care. So we say because we cannot adopt as it is, so we had to adapt for these people who are using drugs, because we know that they have their context is different from the general population. So next. As literature show that this we all acknowledge that the people who are using drugs, who are living with HIV, they have they may experience their own unique challenges compared to the general population, but also the adaptation will facilitate their acceptability, their engagement, and also the buy-in, as they always insisted that nothing can be done for them without them. So that's why it's very important to do adaptation. Next. So continue with this psychosocial intervention in a brief. As I said, it's a peer-led group which conducted by different age, between the younger and maybe we can say older, also men, female, because they are also, it has an issue related with the gender. That's why it emphasized to be run in a different subgroups between male and female, the younger one and the older one. Another thing which component that is being addressed in this psychosocial intervention, it's empowered the people to try the new things, and here the focus is to improve, to manage their health, also managing their attendance to clinic, but also managing to adhere to the clinic and the overall daily life. But also it involves personal to put the personal goals regarding his or her health, but also social well-being, and as well as economic well-being. It also has a component of assertiveness, but also it helps within the group someone to be able to spot ability to spot the skills and the resource that he or she has, so that they can use those skills to managing their health, as well as their overall role in their community, at a family level, and at the society level. Next. So as objective of this study, the first objective is to get from the perspective of the client, the peer who are in recovery, healthcare providers, to assess their needs for this psychosocial intervention, also their acceptability for this intervention, and then to adapt it accordingly. Then the second objective is to pilot test to determine is it visible or its practicability, as well as its short-term clinical and psychosocial outcome that we are going to measure compared to the usual care. Next. It is a mixed method with both qualitative and quantitative, as I said earlier, at the integrated clinic for medication-assisted treatment and HIV care. And these are the participants whom I've already said that people who are using drugs living with the HIV, but also healthcare providers. We have expertise in mental health and also expertise for that intervention. And these have been selected purposeful based on their role, like for those who are expertise and providers, but also because they have based on their experiences. Next. So we have a framework which is guiding the adaptation of intervention, which I've shown to have to be evidence-based. By the abbreviation of which have this step, that the first step is to do the assessment, but also the next step is to do decision, adaptation, and production. And for our case, these three steps, they are going to done, we can say parallel. And then another phase, which is to consult with the topical people who are expertise in this NAMWEZA intervention. And then the next will be to integrate what we have found. So after I did the assessment, and then what we have found, we presented it in a meeting with engaging those people who are using drugs living with the HIV. But also we engage expertise in the mental health field, also expertise in NAMWEZA intervention, as well as their peer who have already managed to graduated. So we shared the finding from the assessment, and then for them to discuss, to make a understanding of what have come out, and then also to propose based on what also they think that it will be more visible and acceptable. And then from after these three phases, we managed to come up with a draft, which we shared with the expertise. And then the expertise, they worked on it and also did the integrated based on the expertise. And then we managed to come up with the draft one of the adapted psychosocial intervention. I'll talk more about what we found as a different from the original one. And then the next phase, which will be part of piloting, is to train and to test, which is during the pilot. So as I said, every phase of this framework prescribe different method for each phase to be used. Next. During the piloting, and then I'll come back to the findings. Well, these are the outcome measure that we are going to assess during piloting. For as I said, it will be clinical and psychosocial outcomes. For the clinical, we are going to assess the depression using the patient health questionnaire. And this, it will be, during pilot, it will be a time series pre and post test that we will have collecting data, 3 point collection before, and then we'll do training, and then starting the session, and then later on, we'll collect again the data. So for the clinical outcomes, our main outcome is the depression, but for the psychosocial outcomes, we have as I said earlier, the self-efficacy, HIV stigma, perceived HIV stigma, it will be assessed used HIV stigma scale, but also we assess knowledge about HIV. We have a questionnaire, which it has been used here in Tanzania, by demographic health survey to assess the knowledge of HIV. But another clinical data, which is part of our routine clinical data, also will extract and assess them, is about their antiretroviral adherence, their level of hemoglobin, their viral load suppression, and also social demographic characteristics. As I said earlier, we will have a baseline and endline data collection time point. Next. So as I said, for the pre-intervention, that these are the participants, and this is who will be engaged. That's the people who are living with the HIV. This is during piloting, and then also post-intervention, we will have apart from them, after receiving the sessions for the adapted psychosocial intervention, which will be led by their fellow peer, but we'll also having the focus group discussion to learn their experience during piloting. And for also one of the, another thing that we'll collect data is about, we'll be observing how do they implementing to assess the implementing fidelity process and the evaluation. So next. As I said, it will be a pre and post-test design. So we'll use an interrupted time series to determine the short-term effect of this adapted psychosocial intervention with those, as I presented, primary and secondary outcomes. And also for the focus group discussion, we will use the thematic analysis, but also for the adaptation, we did an individual interview. Also, we have used the thematic analysis to assess for the adaptation, but as well as during the post-intervention that we will come to assess the barrier and also the facilitator for the piloting. Next. So these are the results for the adaptation process. As I said, we have a formative exploratory where we did an individual interview. We conducted 20 individual interview, and also we did a focus group discussions. And this, what we have found which came out is about they propose at what time that they need the group's session to be conducted, which is during their clinical attendance, the days that they think it will be doable for them. But also they've proposed duration, because the initial, the original one, the group session are conducted up to 4 hours, but for them, they ask for 1 hour at maximum 90 minutes. And also they give us about the group composition. This was, there was debatable. Some of them proposed to conduct different based on age, on sex and age, but some, they thought that there's no need for that. But so we are still consulting them. When we come to the final draft, we'll reach a consensus how it is going to be. With regard also to facilitators, initially it was proposed that the one who have graduated, that they should be a facilitator, but majority of them propose that themselves they need to be trained to be a facilitators. And also another thing, it's about the content. With the original intervention, there was a lot of examples which they have been prescribed from that manual. But for them, they insisted that it's better for them to share their own experience rather than having a prescribed experiences. So still we are continuing to analyzing what we have found. But also what we realize, most of them, they are not aware with this NAMWEDA content. So that which inform us that we need a lot of pre-preparation before starting to pilot. And also during their consultation with the expertise, what also came out, it was we developed and discussed about how are we going to train facilitators, because what we came out is that they propose themselves to be facilitator, because for the general one, it was though they were peer, but the one who they were found to be more literate and more with some experience with the psychosocial, but for them, they think that themselves. Next. Okay. Oh, this is appreciation, but before that, the slide number 19, please, Sherry. Can you go back a slide before this one? These are the anticipated manuscripts, and maybe I can also continue. These are the content that as I was being presented for. These are the example that the example that have been prescribed in that manual. So for them, they suggest that they will share their own experience rather than having a prescribable examples. And also another thing which also it was, we can say, somewhat more different from what it was. There was a session with this psychosocial intervention which focused on the love, relationship, and feeling, and that they themselves, we got difficult for them to. It was more, they thought more of intimacy, but we have to explain, and we will need to modify it for them to understand that this is focused on the personal love and also community love, and also improving relationship in how you apply those skills in managing their health. So it will, as I said, that we are continue to do analysis. We hope to continue get a more picture or a more content that will suit them. Yeah. So these are the one which I said that the example that have been prescribed. So next, please. Okay, so these are the anticipated manuscript. This one, the first one, maybe I should explain brief. This, it will be informed, because before going straight to question about the adaptation of this psychosocial intervention, we have what you can say are formative questions regarding their experiences with the integrated medication assisted treatment in the antiretroviral. So we have started the, as we continue with the analysis, we can be able to come up with this, what we can say maybe a formative paper, which will help us to understand their perceived health and psychosocial benefits based on the initial questions. But another one, it will be reporting on adaptation. And the last, it will be on adaptation. So we anticipate to come up with the 3 manuscripts. This one I'll share with the mentor probably in the middle of the March, the first manuscript. And this one we have already do a brief discussion on how it's going to be, but because we are still continuing with the analysis, so it will, we anticipate to start develop it maybe April. Next. And this is my appreciation, and to all of you who take your time to listen to me. And last 2 slides.
And I'm sorry to jump, Dorothy, but it looks like you're at the tail end. We want to thank you so much for presenting. And we have about only 5 minutes for time for discussion. So maybe I can start. Congratulations in advance on your PhD coming in May. So please keep us updated on that. Just to highlight a couple of things that I really like this work, and I like your description of an existing intervention and the rationale that you have for why an adaptation is necessary. I think that's true when all of us are thinking of intervention development or adaptation. It's really important to come up with a solid rationale for why we think we need to change it. And I like your methodology that you described about qualitative interviews leading to a certain methodology to make decisions about how to adapt. I also want to highlight use of peers and lay health workers, which I think is fantastic. A lot of power there for HIV care and helping treat common mental health conditions too. But we also need a lot of rigor when we train and supervise and document fidelity. And it seems like you're very in tune with that. So thumbs up for that. A couple of things to think about as you think about a bigger trial. If you move to effectiveness, I always think it's helpful to come up with you're measuring a lot of really important outcome variables, both HIV care and clinical and psychosocial outcomes. It's always helpful to think ahead about like drawing out a conceptual model. And I know that you're learning more about mediation analysis. So you can kind of think about what are the, if this intervention is effective in these ways, why is it effective in that way? And you came up with some really important ideas about self-efficacy and stigma. So those might be some of those things that you're thinking about with mediation. And then also thinking ahead about, you don't have to answer this, but what are some appropriate comparison conditions? Currently, I believe you're using a historical control, which is very appropriate. So, those are things to think about.
Can I ask a question? Dorothy, this is Lydia. This is fantastic here. So can she hear me?
Dorothy, can you hear us?
Yes, I can hear you. Yes.
This is fantastic work. I agree with Patrick. Thank you for sharing it. I was actually, as a psychiatrist, I was curious about your outcomes and again, thinking about the next trial. So these are people who use drugs, but the primary outcome was the PHQ-9 and kind of thinking, can you say more about how many were depressed and how likely that is to change? And then also, are you tracking drug use of drugs as outcomes? What measures might you use for those?
Okay, thank you, Sherry. As I said, our primary outcome for the clinical outcome is assessing depression. So we will screen for the depression using a PHQ-9. And then we have 3 points of data collection that every after 2 weeks before, during the baseline. And then after conducting training to the facilitators, and then they started receiving this, the group session using the adapted intervention. While they are continuing with their clinic, we again assess for the depression, as I said, but also for other clinical outcome that will be extracted from their clinic to see if the intervention have maybe some, we can say, to put it, if it's an impact or some changes to their depression, also as well to other psychosocial outcomes that we are going to measure.
Great. Thank you so much, Dorothy. We might need to end for time, but I'm happy to, we can keep an email conversation about any of these issues. So thank you and your team so much. And
thank you.
Helen, apologies if we push things and it's very late there. I'm going to do better about keeping us to about 25 minutes per presentation, but we can move on now to Helen Jack and her team.
Hear us?
Can you hear me now?
Yes.
Can you hear me? Okay, great. Thank you, everyone. Yeah, like here in Zimbabwe, but really great to hear about the work that Dorothy is doing. So next slide. Next slide. So for the next few minutes, we're going to all take little bits of this presentation to introduce you to our study, to validate a brief screening tool to assess for unhealthy alcohol use in HIV care in Zimbabwe. Next slide. We have all sort of introduced ourselves at the beginning of the session, so maybe people can just say their name as they start speaking. Next slide. All right. Kuda, take it away.
All right, morning everyone. I'm Kuda Takarina with OPHID, and I'll start off with a brief overview of the Organization for Public Health Intervention and Development. Basically, we are a Zimbabwean local organization that basically develops and implements innovative approaches and strategies, basically aimed at strengthening the provision of quality HIV prevention, care and treatment services in collaboration with the Ministry of Health. Additionally, we provide a family-centered approach to healthcare provision, which ensures enhanced access of our communities to comprehensive, not only HIV, but TB and MSCH and sexual and reproductive health services. Next slide. So that map to the left is a map of Zimbabwe, and in the darker green shade, these are the provinces in which OPHID is present. Basically, we're present in 4 provinces of Zimbabwe, which makes up 15 districts and supports 327 health facilities under the government of Zimbabwe. And currently, we are providing clinical and community-based programming to those 4 provinces, and additionally, of late, beginning in October of 2023, we've been providing TB services. So for the 4 provinces, we are running an HIV program called TACT, which is a PEPFAR supported, USA PEPFAR supported project. And additionally, in October, the additional 2 provinces were implementing a TB program, which is basically embedded within the Ministry of Health. And we're providing technical assistance in health system strengthening at all levels, that is within the primary healthcare level, district level, and to national level. And at present, we support around 303,000 people living with HIV who are receiving antiretroviral therapy. Moving to the next slide. So this schematic diagram that you see there basically sums up the OPHID model, where we have 3 pillars. So in the middle pillar, basically is where we have the different projects that we are running. As I mentioned, we run PEPFAR projects that are layered upon Ministry of Health facilities towards meeting the 95-95 UNH goals. And additionally, we also have other projects supported through other partners such as UNICEF. And basically, these are just aimed at achieving HIV and TB epidemic control, also ensuring MSCH outcomes are achieved, improved, and sexual and reproductive health services at the national and sub-regional levels. To complement that, to the left there we have incubator projects. Basically, these are small-scale projects whereby we run implementation research studies that seek to develop and test out clinical and social innovations. And out of that, the evidence that is then generated should then be used to develop standard models that can then be put to scale in the first pillar for improved outcomes across the different array of programs that we support, from HIV, TB, MCH to SRH. And in terms of those incubator projects, we collaborate with various institutions, academic institutions, like in the case of University of Washington. We also collaborate with UCSF, Harvard, University of Cape Town, King's College of London, Barnett Institutes, and a whole host of other institutions. And on the third pillar, we also then provide products and services and support. We basically partner with other local NGOs then to provide models or services that build capacity of these institutions, like improving their finance systems, their organizational policies, management and program data infrastructure for improved efficiencies, compliance, and greater local impact. And below there, we just showcase a number of organizations that we collaborate with, Friendship Bench included, which we'll highlight in a few of the later slides. Next slide, please.
My name is Nalinda, and I'm a nurse by profession, but I'm going to talk about the other study that we are collaborating with Dr. Helen Jack, a K23 study, which is on depression screening and referral treatment in primary care in Zimbabwe. And we thought of the depression screening and referral treatment because Zimbabwe is part of the World Health Organization Special Initiative for Global Mental Health. And we also know that University of Washington is the WHO Collaborating Center, and we have facilities such as the Friendship Bench, the one which is being scaled up in the nationwide. And Friendship Bench is a locally developed and adapted psychosocial intervention that manages common mental health disorders such as depression and anxiety. So the K23 study is actually in a better place to work together with the audit C validation. Next slide, please.
And we're also really grateful to have a lot of University of Washington mentors and collaborators on this project, including Dr. Tessa Madsen, who I see joined the call. She's going to be leading the analysis for this study. So thanks for being here. And then we're really grateful to Dr. Williams, Chandler, and Bradley, who are providing mentorship support on this project. Next slide. So we're going to start out by just giving you a little bit of background about what motivated us to pursue this study. Next slide.
The significance to the study is that we have a high prevalence of unhealthy drinking among people living with HIV in sub-Saharan country, and the prevalence ranges between 12 and 62% in a recent meta-analysis. And unhealthy drinking is associated with worse health outcomes among people living with HIV. And people who have unhealthy drinking identified on BRICS screen can be offered evidence-based treatment. And we have a single study in Zimbabwe that was a net-led cognitive behavioral therapy for people with alcohol use disorder in Zimbabwe that was done in 2020 by our colleague, Dr. Madobiro. But however, we do not have any BRICS screening tools that have been validated in Zimbabwe to offer us a baseline for this to understand the prevalence of this unhealthy drinking among people living with HIV, to offer them the evidence-based treatments. Next slide, please.
All right, so sharing some of experiences of it. We have been supporting integration of mental health screening and treatment in the Zimbabwe HIV treatment and care program, and this has been since 2016. However, in terms of implementation fidelity, this has been low. The use of recommended screening tools, that is, and this has really been attributed to a length of it's been attributed to the length of screening tools, and also limited task shifting. And this is really attributed to the dire shortage of human resources for health within our clinics that offer integrated HIV services within routine primary care programs. And as such, the national guidelines and policies recommend a stepped care pathway whereby screening is done within HIV clinics, and then clients are then are referred elsewhere for further screening and validation. Also, anecdotal information which comes from clinical service providers indicates that alcohol and substance abuse do contribute significantly to non-adherence and defaulting from HIV care. Nonetheless, there is no data on prevalence of substance use disorders amongst people living with HIV, and also there is also no existing tools that have been validated within our setting. Moving to the next slide. So in this slide, we basically showcase outputs from a learning phase mental health screening intervention that was done between March and May of 2021. This was in Chitumbiza. So Chitumbiza is a high-density dormitory town, which is adjacent to the capital city, Harare. In this particular setting, 14,933 people already enrolled in HIV care. We screened using the PHQ2 screening tool. 80% of these were screened, and of these, 4% were at this positive screening. And eventually, these were then linked to Friendship Bench, which is also another implementing partner that implements mental health screening programs using lay cutters. In our setting, we're called GOGOs, who then further on administer the Shona symptom questionnaire, which is a 14-item screening tool, and then further on provide counseling services. And the take-home message from this slide is that given the 80% of people were screened, it shows that the use of breast screeners is actually feasible within, an HIV setting, which is busy with this shortage of staff for further, referral. And within such a setting, it is actually then also further more feasible to also administer other behavioral screening tools. And in this case, we actually see, the possibility of then evaluating the OTC screening tool in our setting, which has not been done before. Moving on to the next slide.
So that brings us to our study aims. So our aim is to validate a 3 questions tools, a very brief screening tool to screen for unhealthy alcohol use among people living with HIV in Zimbabwe. And we think that this is important in the context of both it is feasible to deliver this screening, but also there's a lot of widespread concern about alcohol use and its effects on HIV care here in Zimbabwe. So next slide. So for those of you who are not familiar with the audit C, it asks these 3 relatively simple questions. It was developed from the WHO's audit, but the audit is much longer, 10 questions rather than 3, and 10 questions just is not feasible in a busy HIV clinic, and the audit is what is often used in settings such as this. So the audit C first asks about frequency of alcohol consumption, how often are you drinking, then asks how much you drink at an average drinking episode, and then asks about binge drinking. And the third question, the one focused on binge drinking, has also been validated in other settings as a single item screener, so just one question to assess for whether people have unhealthy drinking. Next slide. So we're doing a cross-sectional tool validation. We're validating both the entire audit C, all 3 questions, as well as the third single item screener, that's 6 or more drinks on one occasion, against 2 different reference standards. First, timeline fallback. So timeline fallback is a gold standard measurement technique to assess the amount that someone has drank. You basically use a calendar and go through and you ask people, so yesterday, how much did you drink? Last weekend, how much did you drink? And you get the amount that they drank every day for the past 30 days. And that really gets at so we'll compare the audit C to that to try to get at, does the audit C pick up unhealthy levels of alcohol use? Can it tell whether someone drinks just a little bit or actually drinks at an unhealthy level? We're also going to validate the audit C against the CD interview for alcohol use disorder. So this is the clinical interview that assesses for presence or absence of alcohol use disorder. So someone could potentially have really high levels of consumption on the timeline follow back, but they might not have symptoms of alcohol use disorder like tolerance, cravings, or alcohol interfering with life activities. And so we really want to figure out if the audit, whether or not the audit C is valid for both assessing unhealthy levels of alcohol use and assessing alcohol use disorder. Next slide. So based on our estimates of the population prevalence of heavy drinking and alcohol use disorder, and to reach adequate power within what is feasible for this study, we are going to sample 532 patients, and we're going to be sampling them from 2 large HIV clinic sites where the staff are already implementing depression and anxiety training and have been trained in MHGAP, the World Health Organization's mental health treatment guidelines. So we think that these staff will be prepared to clinically manage those who screen positive. We have specifically chosen to do this in Bulawayo and Rwanda districts, which speak Zimbabwe's minority language, Ndebele. We think doing some tool validations that almost everything is done in the majority language, Shona, but we have really chosen to focus on validating this within widely spoken but minority language, because I think it's important from a language justice perspective, and it's the site where OPHID most commonly works. So we are going to be sampling everyone presenting for HIV clinic in those settings to meet the criteria listed here. Next slide. So one of the things, in addition to this validation, that we're interested in learning is actually what the prevalence of unhealthy alcohol use and alcohol use disorder are within HIV care in Zimbabwe. This prevalence is not known. There's just a lot of anecdotal conversation about it being very high. So we're going to randomly select patients from those waiting in the area, in the clinic area, who are waiting for their HIV visit. And an HIV research nurse is then going to consent those randomly selected patients, and if they consent to participate, the HIV research nurse will collect data via a verbal interview. And we're going to collect the audit C as well as some sociodemographic information and our 2 reference standard measurements. And last slide. Next slide. And then Tessa can answer more questions about this, but our data analysis, we are going to compare the audit C and the single item screener to our binary reference standards and use that to estimate the performance characteristics of the audit C using receiver operator curves and measuring the area under the curve. And that's going to allow us to look at the sensitivity and specificity at each threshold, so each audit C score. To see how it performs, and then we can use that to estimate different predictive values for the screening tool, and we can compare the performance of the audit C to the single item screener. Next slide. So to wrap up, we have not started collecting data yet because the IRB process in Zimbabwe is very slow, but we have really done a lot that we're going to share with you. Next slide.
We've gotten the University of Washington IRB. And for the Zimbabwean approvals, we have 4 levels of approval. That is the local study sites, the Bulawayo and Rwanda, which we've obtained, and then the Joint Research Ethics Council, which is the University of Zimbabwe Ethics Council. We have submitted that one, and they are waiting on the reviewers' comment. And the Medical Research Council of Zimbabwe, which we have received approval for the study. And fortunately, we don't have to apply for the Research Council of Zimbabwe approval because Helen is already part of the affiliating research that we are working together. So we don't need to do that. We have MRSs, that we have the local approvals, and we have the University of Washington IRBs, just waiting for the JREC approval. And that this has been delaying, this is what has been delaying getting funding to OPHID for the data collection to start. But now that we have MRSs and the other IRBs, I think we can start working on the logistics of data collection. Next slide, please. And we've done some formative work, which is the tool translation. We've translated the audit and the questionnaire from English to Ndebele, We had mental illness translate those two, and the tools were reviewed by me for Bulawayo, Provincial Medical Director and clinical psychologist who offered feedback. And we plan to pilot these tools and pick additional feedback in the next 1 or 2 weeks to validate the translation. Next slide, please.
And so one thing that's important for timeline follow back is to be able to say what one drink means. If someone said they had one drink, what does it mean? What is a standard drink? Something like a glass of wine or a beer. One of the most commonly consumed alcohols in Zimbabwe are these very cheap, they're 50 cents for a 200 milliliter bottle, these little plastic bottles of hard alcohol. And the common perception is that although they say 40% on the package, they're often made in people's homes or made quite informally. And many people perceive that the actual alcohol content is far higher than 40%. So when we were talking to our participants in our study about how much they're drinking, we really wanted to understand exactly what the alcohol content of these are, because many people do not trust what is on the label. So we actually partnered with a Seattle microbrewery that agreed to take the samples into their lab to determine their alcohol content. So I brought several samples of these alcohols back to Seattle, and we actually determined that all of them are a lower percent alcohol than it is labeled on the package. So all of them are watered down to some extent, but I think that really goes against common perception and will be really helpful as we're trying to both educate patients, but also determine how much people are drinking in the study. Next slide.
Helen, excuse me for interrupting, but just a time check, maybe about 5 more minutes to finish up.
Perfect. This is essentially our last slide.
Thanks, Karen from OPHID here. So in addition to perceived alcohol use amongst recipients of HIV care, there's a lot of anecdotal data. We don't have any prevalence data, but especially within the urban context of substance use, illicit substance use disorder. So this ranges from marijuana use to also some of these kind of backyard produced that are really perceived to be taking ravage on the Zimbabwean urban population and rural, but primarily urban. So what we're really seeking to do is use this opportunity of validating a simplified alcohol use tool to also look at substance use with a single question. How many times in the past year have you used an illegal drug or a prescription medication for non-medical reasons? What we don't have at present is the additional funding in order to integrate this and validate both tools within a larger sample.
Right. Next slide.
Thank you.
So I think we are now really excited, hopefully, to be starting data collection and analysis once we finish getting the last of the IRBs, JRIC. And in terms of anticipated outcomes, we hope we will see if the audit C and single item screener are valid. I think one of the amazing things about working with OPHID is they work in such a large network of clinics and have such support from the Ministry of Health that if these are found to be valid, there is really a lot of potential for widespread implementation around the country. We also plan to create lay language reports, and I think we are actively thinking about how to seek funding to expand the sample from 532 to 1,064, which would allow us to validate the substance use screener as well. So we welcome thoughts that anyone has on how we can be expanding our sample to be able to validate both tools at once and take advantage of sort of the infrastructure that we've already put together. I think that this work will also set the stage for future work studying the implementation of these tools, as well as interventions that can be leveraged once people screen positive. So I'm going to stop talking now since I think we are nearly out of time, but thanks everyone for being here and taking the time to hear about our study.
Absolutely. Thank you, Helen and the whole team at OPHD. I should have clarified the BIRCH funding mechanism earlier, that Dorothy received a Spark Award as an early stage investigator, and Helen received a CPARC Award, which is more for mid-career folks with or community-oriented awards. So thank you. And again, we have about 5 minutes for discussion, and I'll just start by saying really nice work, and I really appreciate the solid rationale for these efforts around the importance of screening due to the relationship of problematic alcohol use and, you know, possible poor adherence to HIV care. And I really heard about kind of barriers to using these kind of screenings, and this seems like a great effort toward identifying a psychometrically sound, much briefer screening instrument. I'm curious, so if you could say a little bit more about other possible barriers to implementation. I did see a comment about limited task shifting. So curious about how you see, you know, if there's a single or a 2-item screen or 3-item screen that works, how you see this actually being used or implemented in facilities and clinics.
Yeah, sure. I can have a go, or Kudo if you want to also jump in. So our experience with the patient health questionnaire, the PHQ-2 use, so that's recommended standard of care for all clients in HIV care and treatment on an annual basis. What we did find in that learning phase in Chichen-Guiza was that, you know, as Kudo said, these nurses are incredibly overwhelmed, understaffed, minimal resources. Even though it was recommended practice, the fidelity was very low. And the reason for that was there was no documentation procedures for that. And once those were instituted, so it was being routinely documented in the patient charts, that the fidelity of that screening increased dramatically, and it was actually quite feasible. So I think with the MHGAC training that's ongoing in Zimbabwe, in addition to working together with partners such as Friendship Bench, that kind of task shifting really requires a really strong documentation system that is actively monitored, as well as very strong stepped care referral pathways, which we worked on together with Helen and are now standard of care in Zimbabwe. So I'm not sure if that answers the question, but I don't know if you have anything you wanted to add.
Oh, nothing. That's comprehensive.
I have a question. I may have missed this, and apologies if I did, but which of the tools that you are currently implementing are you using right now to define a positive screen? And are you going to be able to capture any data on at least the initial sort of completion of some sort of intervention for those who screen positive?
Yeah, I mean, I think what OPHID is currently doing is using the PHQ-2 to determine, and I think that was, if you go back in the slides, that was there's some data on PHQ-2 and the depression cascade of care on slide 12.
And I went with alcohol, Helen, so you can up with the
I think the goal would be able to replicate a similar cascade for alcohol use, where you screen and then are able to refer to appropriate services. Does that answer your question? I'm not sure I'm answering your question.
Are you currently using the single item or the audit C as your positive screen?
Right now, there's no screening for alcohol or substance use in HIV care in Zimbabwe.
No, well, during your validation study, will you be, you know, as you do that study, are you going to define a positive screen based on one of the things you're using, like audit C or the single item? Do you see what I mean? Or you're just doing the validation without treatment?
We will refer people to treatment because we're going to be doing the reference standards in everyone. I think probably we may as well use the reference standards for our threshold for referral to treatment in the validation study itself, since we will have the sort of perfect information and we won't yet know whether or not the audit C itself is valid.
Great, thanks everybody. I think we can move on now to Anna Larson, who's also presenting from a CPARC award, I believe. Great.
And it's supposed to be part of the right.
Yes, correct. I'm presenting on a CPARC award. So hi everyone, my name is Anna Larson. Oh, just went off on the desktop here. It still works, okay. My name is Anna Larson. I'm a postdoctoral fellow here at University of Washington in departments of psychiatry and behavioral sciences and epidemiology. And today I'm presenting on behalf of colleagues at Kenyatta National Hospital, University of Nairobi, and University of Washington on our findings on linkage to perinatal mental health services among Kenyan women attending maternal child health and prevention of mother-to-child transmission of HIV care. So this is our lovely Sikiliza Mama team. We've been working together over the past about year and a half on these aims. And today you'll also hear from my colleague Joanne Mutaki in Nairobi, Kenya, a bit later. And just a note that any photographs of individuals represented were taken with permission and don't necessarily represent a health status. So a bit of background on me. I have a PhD in epidemiology from University of Washington. And as I mentioned, I'm a postdoctoral fellow in 2 departments. I'm aiming to become a faculty member and PI focused on developing and evaluating interventions to alleviate mental health burden in low resource settings, and have submitted next career stage awards, which will be reviewed in 2 weeks. So thanks for your good luck wishes, and I'll pass it to Joanne to introduce herself a bit.
So, hello, I hope I am audible. I am currently, okay, am I audible?
Yep, we can hear you well.
We can hear.
Okay, so yeah, I have a background in a bachelor's in counseling psychology and a master's in clinical psychology from all from Nairobi, Kenya. And currently at that point, I was the research coordinator for the Sikiliza Mama study. And I hope to be a clinician in psychology and neuroscience, as well as a researcher. And also, as an interest of mine is to be able to develop interventions for deaf and hard of hearing populations within my context. I am currently this month very new, 1.5 weeks old in my new PhD program, going to be studying neuroscience. So that's part of a network called ALMA, which is the African Leadership for Measuring Brain Health in Children and Adolescents, funded among different countries in Africa, where we would be collaborating with Uganda, Ethiopia, Ghana, South Africa, Zambia, and some other countries. So I'll be joining a team, try to train African neuroscientists, and I'm very excited. Thank you.
Thanks, Joanne, and congratulations from everyone here.
Yeah.
So I'll move into a bit of background. So perinatal mental disorders are the most common complication of pregnancy and postpartum, and women in lower resource settings are disproportionately impacted. Several characteristics put women at higher risk for perinatal mental health disorders, such as HIV. So many of you know, living with HIV increases risk of perinatal mental illness by 50%. And women at high risk for HIV also have higher risk of mental health issues. And despite the exacerbating effects of perinatal mental disorder and HIV, alarming gaps still exist in availability of mental health services in settings with high HIV burden. And among perinatal women experiencing adverse psychiatric symptoms, about 75% of them did not receive that needed care. And this could be due to low availability of services or other access barriers. And there's growing advocacy to integrate evidence-based mental health care into health services that are already well attended by this population. So this includes maternal child health services, which are extremely well attended in Kenya, as well as mother-to-child transmission of HIV services. So this advocacy is within the World Health Organization MGAP intervention guide, as well as Kenyan Mental Health Policy and Action Plan. So to inform patient-centered integrated services, we conducted the Sikiliza Mama study, which means listen to mama. We used mixed methods to investigate current linkage to mental health referrals, barriers and facilitators to utilizing facility and community-based mental health supports. And we evaluated preferences for future perinatal mental health services. Within this work, we also explored some inductive themes around experiences with mental health challenges and main sources of mental health distress, and also really explored the influence of male partners on women's mental health, which came up a lot and was a strong inductive theme. Unfortunately, we won't discuss our inductive themes today. We'll stick to our main aims, which were the first 3 items, but happy to discuss those in the future. So we leveraged data and participants from 2 ongoing longitudinal studies among Kenyan perinatal women. The PRIMA extension study enrolls women at high risk for HIV during pregnancy and postpartum in 4 maternal child health clinics in Homa Bay and Siaya counties in Western Kenya. And the HOPE study enrolls women living with HIV as well as women not living with HIV at 6 weeks postpartum and follows them forward in postpartum in 7 maternal child health clinics in Nairobi and Western Kenya. And actually, maybe I'll just say the main impetus for this study was in early data collection in both of these trials. We were realizing that mental health referrals were being offered, and it just felt like a very high proportion of women were refusing that referral, and we wanted to dig deeper and realized we had really readily awaiting opportunities to do that with the quantitative data, and then we also had opportunities to interview women about this further. So in both studies, women screening positive for likely mental health conditions are offered referral through routine referral pathways in either that same facility or a nearby facility. In the PRIMA-X study, women were screened for depression with the CESD-10 and for anxiety with the GAD-7. And in the HOPE study, women were screened for depression with the PHQ-9 and for psychological distress with the Kessler-10. So just bear that in mind as we're looking at our results. We didn't use the same measures in both studies. The Sikiliza Mama study used quantitative data from both parent studies, from the mental health referrals within those studies, and then to better understand the experiences of women either achieving that referral or refusing that referral, we enrolled participants for in-depth interviews from both studies, and we also conducted focus groups to understand their preferences for future mental health services. So overall, we conducted 21 in-depth interviews and 6 focus group sessions among perinatal women at high risk for and living with HIV. And we proposedly sampled women for in-depth interviews for an even distribution by location and a mixture of experiences with attending or deciding not to attend a referral. And a quarter of in-depth interviews were proposedly sampled to be women living with HIV. And we use the theoretical framework for acceptability to inform our interview guide. And then we enrolled 3 focus groups, which met twice, so for a total of 6 sessions. There were 2 focus groups in Nairobi. One of those was completely comprised of women living with HIV, and then 1 focus group in Western Kenya. And we used iterative human-centered co-design methods to understand women's experiences and preferences. Okay, so now I will focus on our results from our quantitative analysis about linkage to perinatal mental health services. So in the PRIMA-X parent study, participants included in the analysis were 28 years old, the majority were married, 9% were employed, and 32% were pregnant at the time of their positive screen. And in the HOPE study, women included in the analysis were 29 years old, 75% were married, and 37% were employed, and 72% were living with HIV. So the PRIMA-X study operationally monitored multiple steps in the referral cascade, and we found that among the 44 women who were offered mental health referral, 77% accepted the referral, so verbally accepted the referral, among whom 46% reported attending the referral. And all 12 women who did attend the referral reported that it was helpful. The HOPE study operationally tracked just attendance to mental health referrals and found that 72% of the 36 women offered a referral did attend that referral. So we also wanted to look at correlates of both verbal acceptance in the PRIMA-X study and attendance to mental health referral. We found that adolescent girls and young women were less likely to verbally accept a mental health referral compared to older women. And in both studies, AGYW were more likely to attend the referral, yet this was only statistically significant in the HOPE study. Regularly employed women in the PRIMA-X study were more likely to accept a referral. And in both studies, employed women were less likely to attend the referral than unemployed women. Again, this was only statistically significant in the HOPE study. And in the PRIMA-X study, this study included pregnant and postpartum women, so we were able to look at pregnancy status as a correlate and found that pregnant women were more likely to attend a mental health referral than postpartum women. We also were able to look at intimate partner violence and found really interesting results here, which maybe will beg a discussion later. So in the PRIMA-X study, we found that women experiencing intimate partner violence were more likely to verbally accept a referral, but less likely to attend that referral. Whereas in the HOPE study, we found that women experiencing intimate partner violence were more likely to attend the referral. So a little bit of mixed results there. And then in the PRIMA-X study, we also measured resilience score, and we found that women with higher resilience scores were more likely to attend mental health referral. Let me just also say, we also looked at HIV status in the HOPE study and didn't find a difference in attendance to mental health referral between HIV positive and negative individuals. So I will now pass the mic to Joanne to present our results on barriers and facilitators to attending mental health referral.
Yeah, so I will now present our qualitative findings. Next slide. So we had key themes of the barriers and facilitators as reported by the women interviewed in the in-depth interviews. We had, as you can see here, lack of confidentiality, stigmatized context, fear of judgment are some of the barriers, well as trusting the provider, having HIV-related fears dispelled, and mental health support via other health visits, among others being facilitators. I'll demonstrate this out in a bit more depth via illustrative quotes. Next slide, please. So women were discouraged from seeking support when their mental health symptoms were rooted in stigmatized topics like HIV status and experiences of intimate partner violence. One woman said it was quite difficult talking about it because I was still traumatized. I found out that I was not only pregnant, but I had also been infected with HIV. So I was very stressed and was not able to share with anyone. That was a postpartum woman in Nairobi. But another one also in the same area stated that sometimes you would feel you're low. There are ups and downs in the house. The man threatens you. So you feel it would be better if you don't exist. So you just have to handle it on your own. Next slide, please. For some women, one's familiarity with a provider was a barrier, whereas for others, their lack of familiarity with the provider prevented their care seeking. This woman, for example, in Western Kenya, did not want to speak with someone known to her when she said that if you're sharing with somebody who you do not know, who don't know you much, to me, I feel you'll be free more than the person who knows you better. This other woman in Nairobi was more comfortable opening up to someone she knew when she said that you can start with the nearest person, then if it overwhelms you, you proceed to professional help, like you can start with a friend. Next slide, please. So I will discuss some facilitators. The key features of care also motivated women to utilize mental health support. Trust in a provider was a main motivator. One woman in Western Kenya said, even when we were speaking, she was talking to me with respect. That is why I was confident. That was a woman in Western Kenya. The anticipation of feeling free after discussing one's mental health was a key facilitator. One woman said that once I share, that load is off of me. It is better than keeping it to myself. I feel it would be better if I share so that it gets off my chest. While another one stated that the reason why I feel free after talking is because I don't have many stressing thoughts. Finally, women were motivated to receive mental health care that was tied to other health visits in the MCH or PMTCT services. About MCH care, one woman stated, it is important during antenatal because you could be pregnant and you have 1, 2, or 3 things you are going through and you can't share with anyone. And with such stress, one could harm themselves or harm the child. And so it is also important at that point. About PMTCT, one woman stated that after knowing my HIV positive status, I was enrolled in the NGO Dream Girl. I felt sorry for myself. I was confused, depressed, and traumatized. That was talking about her mental health. Didn't feel that weird to me because I was already talking with others there now in the NGO that she was already engaged in. Now I will pass on the mic to Anna to continue. Next slide.
Okay, so we've talked about linkage to perinatal mental health services as well as women's voiced barriers and facilitators. And now I'll present some results from their stated preferences for perinatal mental health services. So as I mentioned, we used human-centered design methods in these focus groups. This included journey mapping to uncover locations and people within the community that women seek for support, hypothetical cases, some role playing, and ultimately a ranking exercise to rank intervention elements. The first day of the focus group sessions, so all 3 groups had 2 sessions. The first day was focused on women's strategies for managing their mental health distress and preferences for mental health support, as well as starting to brainstorm potential services. We wanted to end that day with the brainstorming session to just kind of warm up women about even the idea of imagining what could be. I think that women's voices are not often incorporated in that way, so it wasn't comfortable right off the bat. In day 2, we really focused on a group design prioritization session with the ranking exercise. And you can kind of see how the ranking exercise went in the bottom 2 photos. So this is a bit overwhelming, but I just wanted to mention there were different aspects of evidence-based psychological interventions that we used for the ranking exercise, and different aspects had, a number of options that women ranked, and for each of the aspects, women were also welcome to offer other options. So for instance, we talked about modality. Is this an in-person session, a telephone call, something over SMS or a TV show? Or we asked about format. Do you prefer individual or group sessions or a mix? Anyway, you can see there. And so overall, the top ranked elements of potential prenatal mental health services differed by a bit by location and HIV status. So regardless of HIV status, postpartum women in Nairobi desired mental health services that were delivered in a health facility by a counselor and through a mix of individual and group sessions. In contrast, women in Homa Bay preferred individual mental health support delivered in a church by a pastor. Across all the sessions, content areas of spirituality and financial skills were the top ranked content items. And this was interesting, and you also saw this come up in the in-depth interview results. There was a mix of whether women were more comfortable speaking with someone that they knew or someone that was a stranger to them. And so in Nairobi, among women living with HIV, they preferred someone known to them, whereas the two HIV negative groups preferred an unknown person. And also interestingly, the women in Nairobi who are living with HIV preferred a telephone interaction. I think some of that was confidentiality reasons, some of it was frequency reasons. The frequency of being able to contact someone at any time. And then in both of the HIV negative groups, regardless of location, they preferred an in-person session. And then we also asked about the most preferred qualities of a provider, like their capabilities as a provider. And we found that women living with HIV in Nairobi most preferred confidentiality in a provider, whereas the two HIV negative groups preferred problem-solving skills. So I'm going to pass it back to Joanne to share a few illustrative quotes.
Okay, so from postpartum women about their ranking process, we will discuss a quote from one woman in Nairobi who preferred health facility-based care. A hospital like the one in Riruta, you can find at this hour, maybe there are doctors there, and that colleague, at least you can talk to them. You are relieved about the issues you are having with your husband. Next slide. And a quote from a woman in Western Kenya about her preference for mental health support in a church stated that, I would wish to have that discussion inside the church because sometimes you don't have the money. Sometimes the church has a private room where issues are solved and nobody would enter the private room. Next slide, please. So both groups of HIV negative participants desired their provider to have strong problem-solving skills. And one example is a woman who stated that when I want to go and get assisted, I start with problem solving before secret keeping. That would be confidentiality for this woman. Next. Yeah, so Anna will continue. Yes.
So I'll just go over some of our key takeaways. So overall, from our mixed methods evaluation of perinatal mental health service utilization, experiences, and preferences, we found that attendance to mental health referrals was suboptimal, and this was particularly low for women who were employed, postpartum, and over 24 years old. Key barriers to utilizing perinatal mental health services included lack of confidentiality and fear of judgment, while key facilitators included trust in a provider, the perceived relief from mental burden that would be found, and ease of attending a service in MCH and PMTCT. And Kenyan perinatal women have clear preferences for elements of mental health support that should be incorporated as Kenya expands mental health services. We found signals that these preferences may differ by HIV status and location, although we do want to note the few focus groups that we are drawing these results from, and this should be further explored when developing mental health services in these contexts. A few next steps. So we're currently disseminating this work. The team recently attended the Kenyatta National Hospital and University of Nairobi collaborators meeting in January. And we presented this work here as well as the inductive themes that I withheld from you today. And we also submitted an abstract to interest. We are working on 3 manuscripts. The first would cover these results that we presented today, and then 2 separate ones for the inductive themes, essentially. We'll also talk about some grants in the works or awarded. So a few months ago, we received an NAMH-R01 with MPIs John Knuthia, Keshet Ronan, and Amrita Bhatt, which was able to utilize in the grant process some of these preliminary findings as pilot findings. We're calling this the Integrated Perinatal Mental Health Program. It's a stepped care model for perinatal mental health in Kenya, which includes a package of interventions. First, universal screening in MCH and PMTCT for depression and anxiety. Problem Management Plus, delivered by trained lay counselors. It's actually HIV testing counselors as well as mentor mothers for HIV negative women and women living with HIV respectively. And then telepsychiatry by a psychiatrist or a higher trained professional for more severe cases. As I mentioned, I have 2 grants submitted and getting reviewed shortly. They are both kind of actually leveraging the influence of men on women's mental health piece and intending to design interventions for male partners. And happy to discuss those further. Also, Joanne Mutahi and Mary Marwa both were accepted to the Welcome Mental Health Data Prize, which invites African early stage investigators to form teams to compete for funding to answer the question, what are the active ingredients that make a difference in preventing, treating, and managing anxiety and depression in young people? So looking forward to hearing that experience. It involves some training sessions for a few months leading into like forming a team and coming up with a project. So thank you to study participants and the parent studies, as well as our funders here and our collaborators. Very much.
Great. Thank you. And thank you, Joan, also for presenting. I'll start with a couple of comments. So great to hear about this work. I particularly appreciate that human-centered design co-design methodology. Seems like it really yielded a lot of really helpful information to help you design sort of interventions and things like that. 2 questions, I'll kind of wrap them together. I appreciate the efforts to kind of look at the unique experiences of women who are living with HIV versus those who are not, and kind of thinking about what are their preferences. And there are a lot of overlap, but some distinctions, and I'm wondering if that's going to influence kind of your next steps and how. And similarly, just thinking about the trajectory from identification of mental health issues to the referral to the actual treatment. Like, where do you really want to intervene? Is it that referral process to maximize people accepting something that they follow through at least once on, or is it like the intervention, or is it both?
Yeah, thank you for those questions. I think I'll start with the second question. So I think when we started this work, we imagined that, or we hypothesized that women were not accepting referral or attending referral because the service that was offered was somehow not what they were hoping for, or not comfortable for them. And so I think we started off thinking the place to intervene is with the intervention, like improving that in some way to make it desirable. And I still think that is a large piece of it. I also think more toward the early stages of the cascade. I just think psychoeducation and some messaging about how common perinatal mental health challenges are, just pretty light psychoeducation from the point of that referral, about why this could be helpful, and destigmatizing language and kind of validating language, I think would be helpful. So I think those two areas are needed for intervention. I think making services that are really desirable for women, as well as informing them better about why this might be helpful. Now I've forgotten your first question.
That overlap and distinction between women living with HIV and those who are not.
Yeah, thank you. Yeah, I actually didn't imagine that we would see that many differences. We did see more than I anticipated. However, I kind of attribute multiple of the differences in what women living with HIV shows as their preference as something underlying about the strong importance of confidentiality, which I think, HIV negative women wouldn't disagree with. So I think there's still room for introducing interventions that work for both groups well and meet the needs of both groups. But with some, specificity and attention to like the most salient differences, I guess. Maybe Joanne might have some thoughts about that. Joanne was involved in all focus groups and in-depth interviews, and the focus groups were extremely lively. There were kids present. There were, it was, I think, a really fun experience. And so, Joanne, you might have some insights about the differences between women living with HIV and HIV negative women, or similarities.
Okay, I think what you said was pretty much the picture that we got. And just understanding that women living with HIV were more concerned that whatever they were discussing would not be exposed to people who knew them or people who were living close to where they were living. So therefore, these were the women choosing to go to the healthcare facility. And sometimes even the distance, they didn't care if it was near or far. Most of them preferred a facility that was quite far from them, which has also been found in other studies, given the state or how people take HIV in our context at the moment. However, we are learning that with time, the stigma is kind of decreasing, and we hope that we could have services that would serve both of them. It's not that the HIV negative women did not consider confidentiality as important. They only thought that they had problems that were more pressing, and it doesn't matter whether the problem is shared with people who knew them, of which they were still also concerned about that. But as long as their issue was solved, or they were given skills towards prioritizing their main problems and trying to solve them, then for them that would be a priority as opposed to the confidentiality bit. Yeah.
Maybe one other thing, it sort of struck me that a discrete choice experiment might be an easy, an interesting way to take this data on different attributes that they were interested in to like a larger sample, and then potentially do latent class analysis to identify different groups of people with different preference profiles. That's not part of your R1, is it?
Unfortunately, it's not, but I think it's something I've definitely thought about, especially exploring some of those differences between the groups and getting a more rigorous understanding of attributes that are preferred. So I think there could be opportunities, while it's not part of the aims of the R1, but to build something off of it with, someone's F31 or a supplement or something like that. I totally agree with you.
You guys get interested, I can link you.
Thank you.
Well, if you do that, follow up on with the discrete choice experiment, I think you could stand out from a lot of usage of those models by taking the stuff you've done with the human-centered design and actually formulating some hypotheses about, especially if you're going to go in a class direction, identify some a priori structure you might believe, patterns of preferences you might expect. And that would be a much, because I think most of them are very exploratory. And so you could bring that to it.
Thank you. Great suggestion.
Great, well, thank you very much.
Thank you, Anna. Some more?
Why don't we take a 10-minute break and then we'll come back for a conscience.
All right. Unmuted.
Hi, everyone. My name is Kancha Vaswani Pai, and I'm going to be speaking about a study on single session narrative psychotherapy at an HIV primary care clinic, where we're navigating some very intense wait times for psychotherapy services. So just want to thank my fabulous study team, Sarah Kukre is my RC, Sam Jackson and Lydia Trastiak, co-directors, and Dr. Trastiak is also my mentor, and Aina Emmanuel, who is one of the key study interventionists. I also want to thank BIRCH, of course, and yeah, this is my 4-month-old, and I want to thank him for just making me a better person, right? It's been fun having him around as I do this work. So a little bit about my professional background. I've been a therapist for about 15 years. I started my career in India, where I'm from, at a multidisciplinary center for children and families impacted by developmental disabilities. And that's really where I was first introduced to principles of early intervention, multidisciplinary care, family-centered care, as well as the importance of alleviating stigma by promoting awareness as well as systemic change in that sort of disability sphere. And then I came to the United States, did a master's in marriage and family therapy, really kind of increased my knowledge of systemic work. And then went ahead and did a PhD as part of a bioethics and human rights lab. And the focus of that lab was to really shift the focus of mental health care from biomedical paradigms to ones that are more focused on sort of human rights and social justice centered approaches. And then I did my postdoc at the Spirit Lab, which is where I am currently an acting assistant professor in the Department of Psychiatry, and really moved into implementation work supporting individuals living with serious mental illness. My area of focus really is doing building capacity in systems by empowering families in terms of supporting individuals living with psychosis, and more recently integrating mental health care into primary care settings. And clinically, I'm located at the Madison Clinic, which is an HIV primary care clinic at Harborview Medical Center that's affiliated with the University of Washington. Right. Like I said, I'm working a lot in the area of family interventions for serious mental illness. And I recently become much more interested in bringing some strengths-focused and social justice-informed approaches to therapy to the formal evidence-based, specifically narrative therapy. These are the projects I'm currently involved in, and I think my biggest challenge right now is time management. But we all deal with this. I feel solidarity smiles. Okay. The current project is to look at, so it's a Spark Award, so it's an initial look into the acceptability and feasibility of this single session intervention, and refine our research protocol, think about what measures we're using, whether it fits into the flow of the clinic's day-to-day operations, and also see whether it's acceptable to referring providers in the clinic, and see what impact it may have on some clinical outcomes. So a little bit about why single session therapy, and as you all know, there's a lot of individuals who live with HIV with psychiatric comorbidities, and they experience several barriers to accessing mental health care. Some of these include really long wait times, the stigma. I think we've heard about that in previous presentations as well. The other big barrier is attending regularly scheduled appointments, so weekly appointments or bi-weekly appointments. And in general, the psychotherapy literature indicates that about 1 in 5 clients drop out from psychotherapy. And the other big barrier is just limited providers. In our context, we have a huge therapeutic provider, Seattle Counseling Services, that serves the community that because of the pandemic and funding issues recently shut down. And this has dramatically increased the problems with provider access. So single session interventions are designed to be offered within existing care systems or as standalone models. And of course, we're offering it as part of integrated care in a primary care setting. And it's really focused on diving into a specific problem and helping people develop an action plan to make movement towards addressing that specific problem. The goal of single session work is not to do a lot of diagnostic formulation and assessment. It's really to get people moving into whatever it is that they're addressing in their lives. And because it's not focused on diagnosis, we can sort of address a wide range of presenting concerns people bring to the session. So there's a lot of renewed interest. These models have been around for a few decades, but there's been renewed interest because of these issues of increasing needs of mental health care. And there's a lot of data with children, with adults, with families and couples to address problems like anxiety, depression, self-harm, interpersonal challenges. And one of the really interesting things that meta-analyses indicate is that the observed differences or impact of single session parallels those of longer term therapies that are targeted for 16 weeks. So that's a pretty big impact that has been studied. So at Madison Clinic right now, our wait times for psychotherapy is 6 months. So from the time somebody makes an intervention to the time that we're able to schedule them, that's ridiculously long. It's just by the time we get to that 6-month mark, either people's problems have worsened, and that sort of puts them at risk for other maladaptive coping strategies, or they lose interest, or they lose the trust of our clinic. And that's a big issue because we're a medical home for a lot of people living in the community with HIV. The other challenge, like I said, about access of providers, we have limited FTE for therapy providers. And I think parallel to the literature, the people who are impacted most in terms of lack of access to care is patients who belong to minoritized groups. So this was a snapshot of our study population. So this is the demographics of our waitlist. This was back in June 2023, and we had about 63 patients on our waitlist then, and that's actually almost doubled. I checked yesterday, and it was 109 patients on our psychotherapy waitlist. So the demand is sort of increasing. Nothing's decreasing here. Right. So why narrative therapy? I should have said in my introduction, I've been practicing narrative and postmodern systemic therapies since the beginning of my career. And like other single session interventions, narrative therapy is also not focused on diagnostic assessment, but its goal really is to help people develop and live into more preferred accounts of their lives. And the questions that a person is asked during a narrative therapy session is really focused on identifying their hopes, their dreams, their intentions, their purposes, their values for their lives, and helping them develop concrete steps to move into those preferred stories of their lives. And the idea is to really build on individuals' motivation to change and create a context of competence, or tap into their existing mastery or skills, but sort of amplify it. The intervention has been used pretty successfully in Ontario. About 60 of 80 single session intervention clinics use this approach. And we've been consulting with an expert in Canada, Karen Young, in order to implement this at the Madison Clinic. Right, so just a little bit of a sense of what I was saying in terms of the starting point of an intervention like this is really asking people, collaborating with them about what would really be helpful for them to talk about in the session. So again, we're not starting off with, oh, your provider said you have depression, your provider said you have problems with drugs. You're really collaborating with people and deciding the agenda for the session and what they hope to get out of it. And then you can see question 4 and 5 is really tapping into their resources and strengths and sort of tapping into memory systems in a different way from a solution-oriented and strengths-focused approach rather than all the problems and all the difficulties that they have in their lives. So especially question 4 and 5 are tapping into those sorts of resources in people's lives. And then the question 6 is really making sure that we provide an intervention that's culturally responsive to people's lives. Okay. So this is a pilot intervention study, like I mentioned. I did build in a pre-pilot phase to refine the intervention and our measurement strategy. So the way we're offering it is as part of usual clinical care at Madison Clinic, 2 people already on the wait list. And we're collecting some baseline data prior to the session beginning, and we're actually consenting people after the intervention. We want to make sure that we're testing acceptability in this way rather than inviting them to a research study. And then we have a follow-up after 1 month. That's kind of our design. So I'm really excited to say that our recruitment for our pre-pilot phase is completed. It happened like in a blink. I was kind of shocked that it in 1 month it was only supposed to be 5 patients. We have about 8 consented. So what's interesting is that we were able to outreach 22 patients because we were able to move down the waitlist pretty quickly, starting with the person who was referred most recently. And I think similar to other psychotherapy research, there's some individuals you just never hear back from. Maybe their provider thought that they needed therapy, but they didn't really agree. Maybe things changed in their lives and the phone numbers changed. So we reach out to people 3 times before referrals close. So it's not for lack of effort. So our 8 didn't respond, 10 accepted, 4 declined. 1 was because they were like, next week, I'm not available next week, that's too soon. One was already connected to services elsewhere. 1 said that they were feeling better, that they didn't need therapy. And 1 of them said, that's not enough time. So that, for 1, it was truly not acceptable. So about 9 people, 9 out of 10 who accepted the intervention showed up for sessions. And 8 of them consented to the study. We did our first 1 month follow-up questionnaire and interview yesterday. We also sent out a survey to our referral sources as well as community advisory board to look at their acceptability of the intervention. So a little bit, I want to share a little bit about our pre-pilot data. You can see that we're getting folks who have moderate ranges of depression and anxiety, as well as a higher proportion of individuals who use substances, which is pretty consistent with the population we serve at Madison Clinic. Again, this is all very preliminary data from a very small sample size, but the SSIFT is a feedback tool that looks at the strength of therapeutic relationship, which has been to be a huge predictor of therapeutic outcome. And it also is somewhat of a fidelity tool. Is the person doing in a narrative session what are they meant to do? You can see that the average scores there was 6.88, so pretty high in terms of the therapeutic relationship and intervention fidelity. And 1 to 5 is whether the consultation was useful to you? Would you recommend it to other people? How satisfied were you with the experience? And again, we see very high scores in terms of that feedback. Consistent with other single session intervention research, we see decrease in hopelessness immediately after the session and an increase in hope, which I'm glad was trended in the right direction. So these are promising findings for us to build on for the pilot. A little bit about qualitative feedback. There was some open end responses on our feedback tools. And so we're starting to get a sense here from patients about why it is that this particular intervention is helpful. And they're talking about, they're talking through situations, problems, and stress or anxieties, and reason for their existence was very helpful. Appreciating that it'll help people with emotional problems despite their background. And I think one of the most consistent pieces of feedback we've gotten from patients is kind of shock at how much they can do in a single session. Aina Emanuel, one of the study interventionists, she apologizes, she had a patient, she can't be here. So I asked her to send me a text some of her comments so I can speak on her behalf. And one of the quotes she sent was a patient said, I really thought this appointment might be a waste of time, but it wasn't a waste of time. I'm glad I did it, it was helpful, even if I could never see you again. And then I asked Aina to share from her perspective as a social worker doing this intervention. She's been in the field for over a decade, what her perspective is. And she said, it's very rewarding as a clinician. I feel excited and invigorated when I do single session narrative sessions because I get to witness the energetic shift that happens when people examine the problem story as external from their strengths, skills, and stories of overcoming and building a path towards a preferred way of being. I wish I could do this full time. It did not pay though. Just to say that. And this is a little bit of feedback from our advisory board and our providers. So I think our providers are a little skeptical about whether or not a single session can be helpful. It was interesting in the earlier presentation, the friendship bench, that one session makes a difference, and I was like tapping Lydia and saying, look, that one session could really make a difference in people's lives, but our providers are really concerned, and I understand because, the people that we see in Madison Clinic live multi-stress lives, they have a lot going on, but I think that that's partly why embedding this intervention within integrated primary care settings where we have social workers, where we have physicians as well as other accesses can really help in a single session to figure out where a person might need additional services and triage accordingly. It might make our triage much more efficient, as well as build trust within the system. One person points out, I think, which is very one of the big rationales for single session interventions is that making people wait while they are in need now is an ethical concern that potentially these interventions could address. So here again, people are expressing that it's a good option to get people moving, but the issue about complex needs. So I think that one of the things we're really trying to figure out is sort of what mechanism is at play. So again, narrative therapy hasn't been really rigorously tested in studies like these. So we're really trying to figure out what mechanism is at play. I think we would really appreciate some of your brain power in helping us think about this. And which measures to use that align with the intervention philosophy of being strengths-oriented, resiliency-focused, rather than going straight to dysfunctional pathology. So that's kind of what we're trying to figure out right now, as we finalize our measurement factory. And I've also been thinking a lot about how a single session intervention might lead to more effective service utilization, because one of the things we ask patients, so I should also say that the way that the intervention is designed, it's not a one and done thing. People have the option to remain on the wait list after the single session, or they say they got what they needed. And of the 8 people that we have worked with, the 9 people that we worked with, about 3 of them said they do not want to remain on the wait list anymore. 2 said, well, maybe I'll need 1 more session in 6 months. So that means that would be about 2 sessions in a year for a provider, which is much more effective utilization of our time. And then about 4 said, no, I want to remain on the wait list. Right, but I think one of the things we're thinking about testing in the pilot is, well, okay, so would you want more of this single session work? Would you want something else? Like an 8 session or 8 to 12 session manualized treatment? Like, what do you want, right? Because if you only want 3 single sessions in a year, that's much more effective utilization of our resources than 12 sessions. Now, again, there will be individuals for whom that weekly cadence works, but the idea is that this becomes one in a menu of options we can offer within our clinic. And also that we can identify people quicker who need more acute services, because if they're sort of languishing on the wait list as they get worse, or our social workers have to deal with they have about 80 patients on their caseload, and it's hard for them to kind of figure out or help people when they are more acute needs. So it might help us triage patients who need more immediate care, and rather than downstream when things have gotten really bad. I'm curious about if anything else pops up in your mind when we discuss. We're also implementing the same intervention, but as a walk-in clinic intervention at the Aurora Commons, which is a low barrier clinic serving people living with HIV or high risk of contracting HIV. And Lydia is the PI on that project. And so I think it would be really interesting to kind of compare the findings from an appointment-based single session model versus a walk-in model. And I'm curious about the friendship bench. Is it walk-in? Do people make appointments to go to the friendship bench? I mean, I think that'd be interesting to look at other single session models within HIV care. So I'm getting some ideas. I'm so glad this is happening because I'm getting other ideas. Collaborate with other single session researchers. I think BIRCH had hosted Jessica Schleider, who's been doing a lot of work in a scalable evidence-based practices lab. And then apply for more funding for a larger trial. Yeah, that's what I have. I think I have time.
Yeah, excellent. Thank you.
Thank you.
Start again, if you don't mind. Well, I love the intervention. I love the focus on a single session intervention for all of the reasons that you said, and also including that it can be applicable transdiagnostically. I think a real strength. The more you may be doing this, but despite that, it's for everyone. The more you can characterize your research sample and say who they are, the better. So not just PHQ and GAD scores, but if you can give us information, or when you publish, on what are the range of actual diagnoses, severity, which you have, I know, HIV care and management and adherence and social service needs. And don't shy away from documenting limitations of the intervention. That's fine, because we don't expect it to be a panacea for everybody, right? And that careful documentation of your sample will help kind of like, who is this working for, under what conditions, and who maybe is it not working for or optimal. It can really kind of
help you out a little bit more.
Yeah.
Coaches.
We have, sorry, we do have releases for doing chart reviews. So I think a lot of that data that you're talking about, we
Right.
can grab from the chart.
Right.
That would be it.
I think I'm struck by this conversation and my own experience about the misalignment between our typical disease-focused, validated scales intervention and what this is doing, which is strengths-focused, and what the patients seem to be saying, which is they get a lot of relief from talking to someone, they find it helpful, they have increased hope. How do you put those two together? The disease model and our typical research approach, validated scales, diagnoses, and what you're hearing from patients.
Yeah, I think that's kind of what we're like navigating, you know, and we're starting to look at scales from like positive psychology, that realm more like resilience, hope, trust in the medical system, right? Like that perhaps or increases in motivation, or feelings of competency that might lead to sort of effects down the road. It was really interesting, share a brief anecdote. In single session work, especially from a narrative perspective, the questions you ask in the session really matter because they tend to stay with the patient, right? It's like that small change, that's the philosophy of single session work. The small change can lead to like more rippling change down the road. It's a theoretical idea. And I had a conversation with a patient once. I haven't seen this guy for a couple of years, but the one thing he remembers is one question I asked in a session and how that has sort of changed his life. And we ended up having a conversation about, what that question did for him. And now I'm sort of like thinking about that, right? What is it that we're really focusing on? And what can we get better at doing and more efficient at doing in a single session when we're really focused on what matters to people? So I think that's a really great question and one that we're kind of trying to figure out, like, what are we measuring and how can we show sort of downstream impact of that construct, like hope or agency or resilience, even if it's state resilience, right, that we're looking at a difference in.
Yeah, no, it's a great question, Julie. And I think, I mean, in addition to how can we show what is the effectiveness of this intervention, I think that's where this kind of stepped model approach comes in around. If this is not the answer for everyone, then how is the therapist identifying someone who needs more intensive treatment? You know, within Madison, they can access that. So really trying to sort out, it's part of the exploratory work of this is what are the steps of the stepped model.
Well, and I think what comes to mind, I love what Julie's talking about is, like functioning measures, right? Like those kinds of outcomes. Is how is somebody functioning in the educational domains and the interpersonal domains and the occupational domains, as well as like wellness type measures. And those I think would kind of capture, particularly if you're working with folks with serious mental illness, where it's really managing a chronic, like there is no remission of symptoms isn't really the outcome, right? Like that's not really what you're looking for. And so I think those measures are really useful here and help people kind of perceive that. I was wondering how you presented it to people when you called them. Like, how do you describe the intervention and what they're signing up for and what's the expectation? Like, do you describe it as you can do this and then you won't need therapy? Or do you describe it like, how do you describe it to them? Like, what do you say?
You will be cured. No, we explain the truth, which is that our waitlist is 6 months. You have an opportunity to have a focused discussion one time with a therapist to begin working and addressing on some of the problems you want to talk about. And then at the end of that, you'll be given the option to we'll ask you whether this was enough and give you what you needed or whether you want to return back to the waitlist. But during the session, we might also decide that you might go to other services. So for instance, somebody who's like, well, I think I would really benefit from talking to someone. We might refer them to Peer Seattle. Peer Seattle now has a 28-week peer coaching service, right? So we got them, we were like, okay, you can do this, or these are a list of AA meetings, this is the quit line. So like, we could also make some other referrals at the end of that session.
That was my question, is sort of like, the friendship, there's this huge bottleneck, right? So it's so hard for people to get access.
Mm-hmm.
And the friendship bench was sort of developed so that lay people could help each other. And I think the peer approach is great. I also wonder about like case managers who are actually funded, like every person with HIV is assigned a case manager. And could some of them be trained to do a little bit of what you do in single session as a sort of a lay, somebody not quite a peer, but who might have some of those skills? And then could you come up with predictors like maybe lower level scores on PHQ-9 and or your hopelessness thing, like maybe there are people who are really acute who really need the professional help versus those who can go for a more lay approach, like triage, basically.
I mean, we have master's level social workers at Madison Clinic. The issue has been that the funding doesn't allow us to practice psychotherapy. And so I think if we could get some permissions that say for a subset of social workers, I think the issue is that they have so much else going on their plate. So the issue again is a capacity one. And I think that when I was speaking with Patrick as well, the question is, can we train peers, or what are the essential elements or ingredients of the therapy that we would be able to kind of pass on to to workers who don't have the master's level or the highest skill, right? And I think we're trying to figure that out as well through both these pilots before we kind of unleash it.
The only, this is great work, and I think you're obviously very focused on the intervention, but I think you don't want to miss the opportunity to also look at what's going on with your wait list.
Yeah.
Because it's sort of this natural experiment if you're finding out who's already had symptom resolution, who's already been engaged with other services, what is your triage protocol? So just kind of thinking of those also as process measures and outcome measures as you go through the pilot.
Yeah, we're tracking every patient we outreach, we're tracking why they said they didn't want it, if they didn't want it. So we're tracking those. And I think we'll be following going on as well.
Because this has great potential in other settings. I mean, we just hear this at every community mental health center. The wait list is 6 months. And
Well, thank you, Akansha.
Please reach out to me if you have other ideas. Thank you.
Great, so we're moving on to our final research project presentation from Jane Lee. And I believe we have Martha. Oh,
Yeah, no.
excellent. Welcome, Martha.
Yeah. Dr. Lee is gonna be by Zoom presenting, gonna be doing my part, but let's see. Just show you.
Here's a baby thing. The afternoon. There has to be credit for productivity there, yeah.
Hi, everyone. Can everyone hear me?
Yes.
Oh, great. Thank you. And thank you, Martha. Great. So we'll be presenting on our SPARK project, which we received about 2 years ago, on adapting an HIV prevention intervention for the transgender Latina community. And I'm so grateful to be able to be here via Zoom, and thank you, Martha, for being there in person. Next slide. So we'll start with, I wanted to start with Entre Hermanos presenting a bit about their organization, and then I'll give some background about myself, and then we'll talk about our SPARK project, and then our plan for next steps and time for questions.
So Entre Hermanos is a non-for-profit organization here in Seattle, Washington. We've been on the community for the last 33 years or so. And our main mission is education and prevention on HIV for the Latino community in general, for the LGBT Latino community, but now is for all the Latino community. And we've been working for the last 20 years with staff, a little staff, I started in 2000 with the agency. That's mean I have almost 40 years working with this organization. And at that time, we were just 2 people, 2 staff. Right now, we are 32. So the organization has tried to close the circle of care around HIV care for the Latino LGBT community. Right now, we have 4 case managers bilingual. We have 3 non-medical case managers. We have a community outreach worker. We have the trans-peer navigator. We have testing for HIV, syphilis, gonorrhea, chlamydia, and hepatitis. And we have the immigration department, the legal department supporting all the LGBT Latino people who are on the deportation process. And thanks to this kind of collaboration with different organizations, including UW and BIRCH, right now we have housing programs for the different areas, because we have HOMLA, which is a housing assistance for people living with HIV. We start the Best Start for Kids program housing, also for youth LGBT. And right now we are gonna start, this is the 3rd city on the United States working with housing for PrEP users. It's a pilot program that we're gonna start right now, which is a great opportunity for us to start this program in Washington and being the 3rd agency on the United States doing this kind of support. We just need to close the circle with a PrEP clinic that will almost get to that point. We have a PrEP navigator, and we started this program like 2 or 3 years ago, and yearly we enroll like over 100 people. That for the Latino community, that's a huge amount. Because the Latino community has many barriers. There are immigrants, undocumented people with no access to health care, health insurance care. And we need, as providers, as an agency, we need to look at resources to fulfill all that kind of needs. Thank you, Jane.
Thank you. Next slide. All right, this is on Entre Hermanos, and we could go on about the amazing work that Entre Hermanos does, and I'm just so grateful to be able to collaborate with this amazing organization. Next slide. And that's really my background. I'm a social worker by training, but really my focus is on conducting community engaged research. So I've collaborated with Entre Hermanos for almost 7 years now, since I joined the University of Washington, and it's been such a great collaboration where we have partnered for research projects, but supported each other in different ways, and really started this partnership based on shared goals and a shared mission to really promote the health and well-being of the Latino community and Latino immigrants. And it's just been amazing to see how much our research has grown and developed, but also how much Entre Hermanos has expanded their reach of services. And it's been such a great collaboration. And also just acknowledging the Spark Award. When I received it, I was an assistant professor. And then since then, I've been promoted and have received such great mentorship from Dr. Susan Graham and Roberto Orellana, who supported this project that we'll be presenting on as well. Next slide. So, and then you could click so just for some background, we know that transgender Latina women are disproportionately affected by HIV in the United States. And within this broader context, we know that transgender Latina women in the US also experience elevated burden of HIV. And as Martha mentioned, there is heightened vulnerability due to multiple barriers and structural barriers due to, their identities as being racial ethnic minorities, gender minorities, immigrants, and a lot of stigma and discrimination that they face. So, before we conducted the Spark project, we did an assessment of the needs and the barriers to accessing health services in this community, because Entre Hermanos has been serving the Latino community, and there have been more and more transgender Latina immigrants who were seeking services. So we assessed some of their challenges, and we see how their intersectional identities really present barriers to accessing health services. And that was really the impetus for this project, because despite the clear challenges that transgender Latina women face in accessing care and HIV-related services, we really recognized that there was a lack of evidence-based research that focused specifically on addressing the unique needs of this population. Next slide. So that was really what sparked this Spark project, where we wanted to adapt an evidence-based intervention for the transgender Latina community. And we also wanted to make sure that we identified potential barriers and facilitators to implementing this type of intervention for this community, with specific attention to promoting HIV testing, PrEP, and HIV care. If you could click. Yeah, and so we really wanted this to be a community-informed approach, and also a status-neutral approach based on our, initial assessment. We saw how it's important to address the stigma associated with accessing HIV-related services, and really addressing the whole person, meaning, not just their HIV-related needs, but also their need for social support and mental health care and other services. And that's what this study was focused on. Next slide. So we use the ADAPT-IT model, or the ADAPT-IT method, which includes assessment, decision, administration, production, topical experts, and then integration of the feedback received from those steps. And then following that would be training and testing the intervention. And so we conducted that needs assessment, which I presented from that paper earlier, which really sought to assess, the behavioral and psychosocial risks, as well as their preferences for intervention content. And we moved to the decision step, where we reviewed existing CDC-defined evidence-based interventions for HIV prevention. And so our selection of the intervention that we wanted to adapt was guided by thinking about the goodness of fit between the original evidence-based intervention and the needs of transgender Latina women. And then we decided on Project Life Skills, which is an evidence-based intervention developed by Dr. Robert Garofalo and Lisa Coons. And it's a 6-session group-level intervention that was originally designed for transgender youth. And it seeks to convey, basic HIV risk and transmission information, but also is based on the empowerment theory, as well as information, motivation, behavior skills model, which seeks to promote HIV-related prevention behaviors that empower the community. And so really the evidence-based interventions focus on transgender women, complemented our aims to address some of the challenges that the transgender Latino community face. And also just the alignment with the theoretical model seemed appropriate for our needs and the needs of the community. Next step. So once we did the decision step, we conducted a theater test of the evidence-based intervention with the community. And this really involved gathering feedback on the content, material, and the delivery of the selected intervention. So first, we presented the materials to the community. All materials were translated into Spanish by Entre Hermanos, with attention to cultural relevance and appropriateness. And so the theater test really involved presenting the the modules and the activities. And then we, got feedback and suggestions. We conducted brief surveys as well as had a focus group type discussion to obtain feedback from all participants. So really this feedback was meant to inform the adaptation process and to guide how we wanted to modify some of the materials and to really develop a plan to, think about how the adaptation would lead to new materials and what characteristics would be maintained from the original intervention. And then after the theater testing, we obtained perspectives from topical experts on the transgender Latina community. So we did some brief interviews and presented the adapted materials to community leaders and members of community organizations. And this was to make sure that, once we conducted the theater testing, made the initial revisions, what did some of these quote unquote experts or community members think about those changes? And does this really integrate and attend to the needs identified from the community? And these are some photos from that theater testing. And so this is just some characteristics of the theater testing participants. We really sought to obtain a range, a diverse group, though they all identified as transgender Latinas, but you can see most were from Mexico, one person from Venezuela, and one person from El Salvador. And then there were 3 people who identified as HIV positive. And then there was a range in age from 25 to 62 years of age. And then about a little more than half reported having health insurance, and the majority spoke Spanish more than English, which is why we conducted the theater testing in Spanish. Next slide. And so with the the theater testing and feedback from topical experts, the final step was really centered on integrating that content and feedback provided by the topical experts as well as from the theater testing. And so we really retain some of the format of the original intervention, such as it being a 6-session intervention, the theoretical models, but we adapted a lot of the content to make sure that it was relevant and culturally relevant for the Latina community. So for example, content on housing and employment was tailored to address some of the specific challenges faced by the community, such as language barriers or immigration status. We also included some additional content on how to address, interactions with police or experiences of gender dysphoria, and then really sought to integrate some trauma-informed practices to address those unique needs and experiences of the transgender Latina community. Also, we decided to integrate a social media component where intervention participants would be connected throughout the duration of the program through a WhatsApp group, because participants emphasized that it would be important to stay connected because the sessions would be conducted bi-weekly. So this would be a culturally relevant way, because most of the participants, or all the participants, said they are on WhatsApp as a way to connect with others. So this could be integrated as part of the intervention to stay connected and share materials and resources that they learned from the sessions and discuss it during the week when they're not in the sessions. And also just from feedback from participants was where we got the program, the adapted intervention name, which is Somos Chingonas, which translates to we're badass or we're strong, capable women. And this term was selected because of its colloquial nature, but also just its understanding in the community and its emphasis on highlighting the confidence and assertiveness of the community. And so really we thought this new title captured the goal of promoting empowerment and self-assuredness in the context of HIV prevention and its community-oriented nature. Next slide. Oh, and so this is kind of the overview of the different sessions that the intervention focuses on. And we also integrated some new outcomes of focus, which the initial intervention just primarily focused on condomless sex, but given advances in HIV prevention, but also given the needs of the community, we also focused on the outcomes of PrEP use and ART use with it in conjunction with condomless sex. But these are the overview of the 6 sessions and kind of how we viewed the different adaptations and changes from the original intervention. Next slide. And so I'll have Martha talk a little bit about, talk a bit more about the adaptation and the intervention and some of the changes that were made, but also some of the results and their presentation at a conference that they were able to present this study on recently.
Yeah, for us, it's very important that all the information that we can provide to our community is on their own language, the language that they speak and can understand. So doing this kind of intervention for us, when we see the first skill intervention on English, and it was for youth, African American, trans community, we decided that it is not the way that we can present to our community. So working with Dr. Lee, we've been able to translate and adapt the intervention to our needs, to our community needs. And we present different personalities well known in the community that the background is Latino. So for them, for our community to be someone from their own community representing on this label, the community is something very important. It's a way to understand that it's not only just being trans, but you can complete your dreams, whatever they are, reflecting on this population. So for us, that was very important. And after that, we saw this conference, the Latino Social Work Symposium. It was a conference in Oaxaca, Mexico. We've been there last weekend for this conference. And the name of the conference was ¿Cómo es que la cultura cura? How the culture can cure. How can we use cultural practices to cure our clients, to empower them, to transform their spirit and support their treatment. So for us, it was a very good opportunity to present this kind of intervention in this conference and this symposium with social workers from all the United States. This is a presentation sponsored by the Social Work School from New Mexico. And it was a success, you know, because I think it's the passion that we have to present the way we conduct this study, and the support, always the support of Dr. Lee and BIRCH. So for us, this is a win-win, because for many, many years, we've been trying to create programs or to create supports for all the Latino community in general. But when we try to look for data for the trans community, never found none, nothing data. So for us, getting this data from these studies, it will help us to support the grant grant application that we've been doing. So we can work with BIRCH and the researchers like Dr. Lee. We can provide new ways of support for the community. And at the same time, we can open doors for new researchers, for new programs, and for the communities that keep coming. Keep coming to our community. So that's very important. And also after this test, we've been able to get funds to create a support group for the trans Latino community. And they decided to name it Monarchas Butterfly. You know, the meaning is the immigration meaning, because it's a community coming from Latin America in the transformation of what they want to be. So we are gonna work with them. We already get 2 grants for them. And we start conversations with another organization, Consejo, to support this group, providing mental health in their own language, which is something that we've been looking for many, many years, because it's not the same thing being bilingual than being bicultural. You know, and if it is difficult to talk about mental health and emotions and traumas and violence in our own language, how difficult could be using an interpreter that maybe won't understand what I'm trying to say, or to someone who doesn't know our culture. So getting mental health for our community in our own language is something amazing. So thank you, Dr. Lee, for your support always. Thank you, BIRCH, Dr. Raham. We've been working together for many years too. So this is what we've been doing and what we are keep working on for many years. I don't know my retirement, maybe 5 years, because I've been working on advocacy for HIV Latinos for more than 30 years already. I'm ready for my retirement, but I want to keep this work and pass it to the young generations.
Yeah, thank you, Martha. Yeah, what I also appreciate is just how our collaboration has led to, new opportunities for Entre Hermanos and, for their programming and their services. And that's what I really think community engaged research should do. And just as a note, we have a manuscript under review that really highlights just this adaptation process, because we know this was the Spark grant really just funded the adaptation of the intervention, but we also submitted an R34 grant application to hopefully pilot this intervention and to evaluate it. And with that piloting, we expanded our partnership with an amazing organization in Los Angeles called Trans Latina Coalition, who Martha is really well connected with them. And so we're hoping to be able to pilot and evaluate the Somos Chingonas intervention in promoting HIV prevention and HIV care, as well as condomless sex. So we're really excited about that opportunity. And, as Martha mentioned, they presented this study at the Latino Social Work Organization Conference, which has been great. We're hoping to present some of our work at the International AIDS Conference. So really doing an integration of community dissemination as well as dissemination to the broader scientific community. And yeah, it's just been really great. Next slide. Yeah, thank you to Dr. Susan Graham and Roberto Orellana, who are mentors on this project. And we're just really grateful for this opportunity and to get funding to do this amazing work. And I'm just grateful for Entre Hermanos and for all of you. So thank you.
Thank you, Jane, for discussion. Well, I'll say, I really appreciate the adaptation process for an existing evidence-based intervention and all of the rigorous way that you did that. And it was really interesting to hear about how you incorporated so many important other elements, like you mentioned gender dysphoria and language barriers and dealing with police and trauma. So really interesting to hear about that. And I understand your main outcomes appropriately are around sort of condom use and PrEP use and ART use. And I'm just wondering if you've heard about any benefits that surprised you, and are you broadening your outcomes to other important areas?
We are including some mental health indicators as secondary outcomes for the piloting. So, recognizing that having access to social support, and some of the content talks about, accessing services and addressing some issues related to self-esteem. So we're also hoping to see potential changes in that. So that is part of our evaluation for the R34.
Great. Other comments?
Sort of interesting, in fact, I've had R34s that do target the ART PrEP and sometimes sexual risk behavior, and at least one of them worked both for reducing depression and increasing ART adherence. The other one didn't budge PrEP at all. We did a PrEP one, and now we're really more interested in looking at our mental health measures. But often for these HIV-related grants, you're required to have an HIV outcome be your primary.
Yeah.
So it is interesting because, how it all works, and over the long term, suppose, it should reduce HIV, just like our substance use grants should over the long term budge HIV as well.
Great. Well, thank you again. Great work. And excited to hear about the